Good afternoon, Dr. Nat Wright. Thank you so much for taking the time to come and talk to me on May the 25th, 2020, 8-10 weeks into lockdown. I've already said your name, which is Nat Wright. Nat, why don't you tell us where you are in the world and what you do for a job?
Well, good afternoon, Adam, and it's really great to see you again. We've been great working colleagues for a number of years now. I think we first met in Sydney nearly 20 years ago when I was doing a presentation on homelessness. So I started working in the addiction field 25 years ago next year, and knowing very little about addictions, but with a big passion to see really good quality care in the UK. Looking at homeless people then, they were marginalised, excluded from certainly addiction services, and there were those in primary care saying they were unmanageable and untreatable, and there was something innate in me thinking, this can't be right. If primary care is as good as we say it is, it must have something to offer. And from there, I've been on a great journey of fantastic highs, a number of lows, where I think hopefully I've been committed to both generating the science and following the science, to use a buzzword, as to where it leads us to best practice in the field of addictions, which I think is where it leads us today around the whole area of smoking. What have I done in those last 25 years? I now run the RCGP course in substance misuse, and have done for the last sort of 12 years or so, and we've seen nearly 30,000 people trained through that course over the last sort of 20 years or so. And I'm the clinical research director for a social enterprise called Spectrum CIC, and we provide community drug services, prison healthcare services across all of the north of England. So yeah, very much immersed in the addictions field still.
So it's reasonable to say you're knowledgeable, passionate, committed, and interested in sharing that knowledge with other people who can make a difference, hence your interest in teaching and training. Now, although both you and I work within prison services and could talk around issues related to drugs and alcohol and COVID, we're not going to do that today. We're going to talk about tobacco and COVID and nicotine. Now, as you already know, we spoke to Robert West last week, and Robert's view was that smoking is not protective to COVID. 40,000 people will die in the UK from COVID this year, but 70,000 will die from tobacco. And he made the point that it's always a very good time to quit smoking. I would like you to tell us a little bit more about the story that led to the idea that smoking could be protective, and a little bit about the nicotine story. Off you go.
Yeah, absolutely, Adam. Yeah, well, it caught me by surprise, it's fair to say. Having spent, as you say, a quarter of a century encouraging individuals, vulnerable individuals, to stop smoking, the fact that smoking could be protective against COVID felt so counterintuitive. Now, yourself and myself, we'll understand the concept of counterintuitive, but for anybody listening who's not immersed in the scientific method, sometimes science catches us by surprise, and something that we innately feel is correct from all our experience, we're wrong. And that's a very humbling moment for us as scientists. Keeps us humble that the world out there is bigger than us, and there's a lot that we don't know. But this was just so counterintuitive. I thought there must be another explanation here.
Just highlight, why was it so counterintuitive? Why could smoking just not be protective against COVID?
Well, because if you look at hospital admissions, the very early data coming out internationally, and the UK supports this, but China was the first, was that there's an overrepresentation in hospital wards. So you're more likely to be admitted to hospital with a COVID illness needing oxygen support if you're male, if you have a long-term condition, or if you're from lower socioeconomic status. All of those subpopulations of the greater population, there's a higher smoking prevalence. So for me as a scientist, you have to go through some real mental hoops to think, well, if these groups where smoking is so strongly associated is more likely to put you in hospital, how then can smoking be protective? What I'd like to explain to you, Adam, is that smoking is not protective, and that actually Asia probably has to teach Europe a thing or two about this. So I was on the webinar last week, and large parts of Asia now, I think India, Bangladesh, they banned tobacco sales during COVID, which I have to say I fully support. And yet we have eminent scientists in Europe saying that we should be doing trials of nicotine to see whether it's protective against smoking. And my question is, being in addictions you have for a number of years, there's a much easier explanation than nicotine being protective. And why, as scientists, aren't we following that method? I firmly believe that if we don't, and that if we believe smoking is protective, those scientists will one day have egg on the face, in the same way that there were scientists when first of all, the eminent scientists said that smoking is putative, that smoking harms health. There was eminent scientists who were being funded by the tobacco industry who denied that, and their reputation was then, severely called into question when the science proved them wrong. We could go back. Global warming is another example where scientists have tried to deny it, but the weight of science in these areas as science emerges is so strong that we end up being looked stupid if we don't have some humility towards what's actually happening here.
So give us the top line reason why the first data may not have been as useful as we'd hoped in determining the link between smoking and COVID. What was missing? What was wrong about the quality of that data?
Well, what was wrong about the quality of the data is that in scientific terms, it relied upon what we call self-report. So in other words, you're the ICU doctor, I'm really short of breath with COVID, I've been smoking up until I can't breathe anymore, and you ask me whether I smoke. What am I going to say? Now, I might say yes, I might say no, but I'll tell you, from all my experience of working in primary care for 25 years, I'm more likely to say I don't smoke. Why do I say that? What gives me authority to say that is that I have such consultations with individuals in primary care, and it's called social desirability bias. So in other words, we give an answer that other people may want to hear. That's not the true answer. Now, that's not to be pejorative towards individuals. Many such people are vulnerable, or they feel they can't trust us for understandable reasons. But the reality is we don't get the right answer. And this is this isn't just in the area of smoking. In primary care, any GP listening to this will know instantly, relate to this story. They say that we do liver function tests. And in mainstream primary care, what we're taught is that if liver function tests come back raised, abnormal, it's usually for one of two reasons, either alcohol overuse or medication. So you can imagine how the consultation goes. And we need to have a little chat about alcohol. Before the word is dried on my lips, patients will say, I don't drink. Almost without exception. I can think of 2 patients in 6 years of the practice I've currently been in an area of high social deprivation who've said, yes, could be alcohol. And the second one was only allowed very sensitive, persistent questioning. Now that's alcohol and mildly raised liver function tests. How much more if I'm really at risk of my life, but also I'm potentially putting your life at risk by having COVID? And I say that with a real degree of gravitas. This is a devastating illness. So what I'm saying is we need better methodology than for the COVID science and what relies upon self-report. And there are methodologies out there.
But so what you're suggesting is within China and other settings, people who actually were smokers turned up with COVID, said they were non-smokers, and so in fact the truth wasn't getting out, and there were all these people who were being reported as non-smokers with COVID, when in fact they were smokers with COVID. They just weren't reporting that. And that's why we got this unlikely looking story.
That's a very pithy summary, Adam. Yeah, there's nuance there. So what might have been going on is what I've just said. I smoked up until last week, but then I stopped. So I self-reported as a non-smoker when the only thing that stopped was this shortness of breath. And that's what I see all the time in primary care. We know it from the addictions field, Adam. You know, we've worked around injecting drug use for a long time. You'll say to drug users, do you inject? No, I don't inject, but you have hepatitis C. Oh, well, there's just that one time when the needle exchange was shut at midnight on a Friday night and I really needed a hit. And so how they conceptualize abstinence from injecting is 99.9 times I don't inject unless I'm really desperate. Now, people might say, well, that's not fair to conflate my smoking behavior with those of drug use. No, it isn't, except it's a human reaction to sort of underplace some behavior that others might see as stigmatizing, particularly the medical profession or healthcare services. So I have individuals, I've spoken anecdotally with my friends and colleagues about this, and they all say, oh yes, Nat, of course we've done the report. It's a bit like me, you know, when somebody was just talking to, when my father died, I just started smoking a couple of cigarettes just to get through the day for a few months, but I was still a non-smoker because I've not smoked all that time. So there's all this going on. I could go on. What about people who are smoking cannabis or smoking roll-ups or vaping? The pipes. You know, there's all sorts of ways in which drugs can be taken into the respiratory system now rather than tobacco. So I think, yes, your summary is a fair one, Adam, but there's a nuance behind it that we need to unpick, I think.
Okay, so is there any possibility nicotine might be useful in the treatment of COVID?
I think you've got my thoughts on that by now, which is why would we want to go down that line of scientific inquiry before excluding the possibility of social desirability bias? When you have males, people with long-term conditions, people with low socioeconomic status going into hospitals, why would we not just do urinary toxicants for smoking toxicants? That's an easy piece of research that's cheap. And that would give us, that would make a significant contribution to science. And if the toxicants are not there, I'm happy to put my hands up and say I'm wrong. Let's now look at nicotine replacement. I would still have a question, why nicotine, not cigarettes? Because if you believe the science at the moment, it's smoking, not nicotine, that's protective against COVID, if you're to believe the protagonists of that line.
Well, okay, but the people who are, I mean, the French government is stockpiling nicotine patches. There are eminent French scientists. I'm not just kind of, suggesting only French, but there's obviously people who have got enough of a story, who I assume aren't daft, who have got someone somewhere high up in the government to say, we are going to give you money or stop the sale of nicotine because you've told us a story that's got a little bit of plausibility. Like, how does that happen? Are you suggesting there's conflict of interest or people ignoring the science for their greater elevation?
No, what I would suggest, Adam, I would say both you and myself, we'll have sat on research funding panels for a number of years. And what I can say is sometimes the obvious doesn't headline grab, doesn't intuitively appeal. What appeals about, let's see whether social desirability biases at play or not. Even the concept is offensive to us as human beings. The fact that I could give you an answer that you might want to hear rather than the truth. It's difficult for me to admit that, and we are at a state, we are at a state where I would say internationally, the state of psychic distress internationally is higher than it's ever been since the Second World War. So we're clutching at things, and we want simple things, easy things. To think through that there could be methodological flaws in the science, it won't grab a headline. You talk about French politicians. Okay, are politicians more likely to read the newspapers than the scientific journals? I'll put that out there. There's a story here that is being told very well by the press because it sells newspapers, is my strong view. There's nothing I've heard that would say that smoking is protective against cancer. And when I heard that the Indian government had banned the sale of nicotine products, cigarettes during COVID crisis, I have to say, if you put a gun to my head and say, well, okay, then what you've told me about the French government, if that is factually correct, would I support the Indian government's position above the French government's position as one that's more reasonable? Yes, I would. I would support the Indian government's position.
Okay, so I guess the thing that's winding you up, something that at the moment is biologically implausible, taken from rather wishy-washy, poor epidemiological data with lots of social desirability bias, has led a government and scientists to go down a route that really they should have never gone down, and they would have been better off doing, as you've said, which is do some kind of carbon monoxide in exhaled air or cotinine levels in your urine, prove that the story is nonsense, and then, do what other people are doing and focus on a vaccine and antiviral drugs for COVID. Like, it seems that you're just offended that this has even got off the ground. Here's
why I'm offended, Adam. My son, who's now 21, in first year as a student at Sheffield University, caught mumps despite having an MMR vaccine. And here's what further offends me, Adam, is that if you look at the World Health Organization's status regarding measles in the UK, we don't have elimination status. Now, why is that? One of the most significant reasons is because somebody called Andrew Wakefield, because of fraudulent evidence, changed public opinion. Now, I could put the question back to you, Adam, when you say the French government really stockpiling nicotine. I could say, really, one person, one fake scientist, taking biopsies from the bowel without consent can internationally change human behaviour. Well, he did. And that's why I'm offended, because I think bad science needs to be called out, and it needs to be called out by us in the scientific community.
Right. So I think when I started this conversation, we were going to have a conversation about molecular mechanisms of nicotine affecting macrophages and T cell count. But in fact, the battle you're talking about is far more endemic and pervasive than a virus. It's to do with fake news, and it's to do with the global body of science not stamping out stuff like this early. And you've just given a beautiful example of the loss of herd immunity with fake stories about MMR and autism.
And I would want to say, Adam, I'm not saying that there's intent on the part of these scientists. You know, Andrew Wakefield, the analogy is good insofar as bad science can change public opinion internationally at a population level for the worse, for the disbenefit of public health. So I'm not saying there's any intent on part of these scientists. What I'm saying is, my plea to the scientific community is to look to the obvious and to look to those who've done science in the addictions field for generations. Because when it comes to social desirability bias, we know what we're talking about. If alongside, we've got new words in the lexicon that we didn't have 2.5 months ago. The R value, the peak, the pandemic. I could go on, social distancing. Did many people in the street know what a pandemic was 2.5 months ago? All I'm asking is two things. Could the public start to become aware of the notion of social desirability bias and therefore look at science and read your newspapers in a more informed way? And here's my big plea to scientists, and I've made this in public and it's a matter of record. I've asked scientists when they're reporting such data to put terms such as social desirability bias in the title. So I don't want these notions buried somewhere right down in the small print. I don't think that's fair science. I think when the obvious explanation, when we have so many people who are men, who have a long-term condition and low socioeconomic status, needing oxygen, Adam, as you and me speak, the obvious explanation is social desirability bias. So I would say as a scientific community, we have a responsibility to have that as the priority. And I would say somewhere in the world, fund an urgent public health study where we can do smoking intoxicants on people with their consent as they're admitted requiring oxygen in hospital. That will give us the answer. Now, if I'm wrong, I'll put my hands up and say, Adam, let's start talking about molecular biology. And I'll say, I don't know much about that. But I've nailed my colours, I think, to the mast, Adam. And if history proves me wrong, I'll put my hands up. All I ask is that other scientists who are very pro wanting nicotine trials will be willing to do the same.
I mean, you raise so many other issues about how you communicate information to the media and how you're reliant on the media taking that information and giving a factually correct story. And unfortunately, there are sub-editors who will go, it's a great story, but that headline, no one's going to read it. And very often, the headline has no semblance of relation to the article. So there's also something around educating journalists.
Absolutely.
Where possible.
Except let's put myself in the position of the journalist. My paycheck depends upon selling the newspaper, sadly. And I've been subject, I don't know whether you have it, but I've been subject to what I would call shoddy journalism, where I've been cut off, for speaking, rational, because it's not emotional enough, or it's not what they think. If they don't think their readership want to hear this, so if you're a journalist for the left-wing press saying something pretty right-wing, well, you're not going to get too much airtime, and vice versa. Yeah. So for me, I'm not about educating journalists. I just want to educate the public. And actually, I would say if newspapers, the reason I've come to you, Adam, is because I know you'll give me a fair hearing. You have given me a fair hearing. I trust you not to edit this, and let's see where it goes. If 5 people want to hear it or get shut off after sort of 20 seconds, so what? At least everything I've said this afternoon, Adam, is hopefully for the benefit of public health. I have a real concern that people who would otherwise stop smoking will read this in newspapers and not stop smoking at a time when they're really vulnerable, and that causes me concern. I've got an even bigger concern that people might start smoking at this time because they'll think, oh, actually, it might be protective, and that will lead to a huge public health burden down the line. We're already seeing some great scientists coming out on, this is the first curve, the COVID curve, but we've more curves to come, which is the delay in cancers that will be coming in the next few months because of the shutdown hospital service. That'll be another big curve of late relatively speaking, late diagnosis of cancer. Then we've got the long-term conditions that haven't been managed quite so well as they could. I was in a prison on Friday having to email, over the weekend to try and get somebody to be seen with very complex eye comorbidity, and this is where we're at the moment. It would have been a very easy discussion, but COVID's delaying all this, not to mention then the mental health trauma curve as we come out of this the other side, So I'm concerned about public health, and that's why I think as scientists we should be, in the addictions field. That's what we went into it in the first place. We wanted to make the world a better place for those that come after us, our kids, our grandkids, our friends, our family. And so I think it's really important that we hold to the highest standards of science, I think, in this difficult time, I think is what I want to say.
It's a eloquent and entirely necessary set of statements you've made, Nat. And I think I would also ask people watching this to always look beyond the headlines. And certainly, 10 years ago when all the novel psychoactive drugs were coming out and there were headlines like drug turns you into a zombie face chewer or, teen ripped his own scrotum off. You just look at that story and go, that's clearly bollocks. And of course it was, but it was a great headline. So, yeah.
And yes, on that note, Adam, that's a very good point. I work in secure hospitals, and the degree of recovery in people with severe enduring mental illness, psychotic mental illness, compared to 30 years ago, it's incomparable. That the life skills they have that they didn't have, they were locked away in institutions until the mid-80s. So I concur, I think this is my plea to the public to look behind the headline and to sort of read it with a degree of, I guess, critical analysis. Well, is there another side to the story? Or if not, get in touch with people who may know what they're talking about. There's a lot of things in life I don't know what I'm talking about, but I'd like to think addictions is not one of them.
Everything you have said today, Nat, I hope will come across as crystal clear, and people recognise it comes from a place of wanting to do good. And the better information people have, the smarter the decisions they can make for themselves. And the one clear thing people should walk away with is smoking ain't good for your health. It ain't good for COVID. So, yeah, do all the other sensible things.
All the other sensible things.
Thank you. I look forward to another day when you and I can talk about our day jobs.
Great to chat to you, Adam.
All right.
Have a good evening.
All right. Cheers.
Bye.
And so the question that you chose to ask, will it be better where we're going? And though the answer I don't know for a fact, still my heart is saying, oh yeah.
Still just taking it one day at a time. Still don't know what I'm trying to find. Really I don't mind, cause I'll be fine. Yeah, I'll be fine. Yeah. No longer focused on yesterday, and I don't care, the rest will say whatever they want. What's left to say? What's left to say? Cause I'm leaving all the pain today, me